Article 43 of the Kenyan Constitution guarantees basic health care for every citizen. But step up to the doors of a public hospital, and that legal promise often dissolves into immediate, out-of-pocket financial stress. It seems like the government realized the old National Hospital Insurance Fund, the NHIF, was a sinking ship, weighed down by ghost claims and a regressive funding model. This demographic chart shows exactly how lopsided that model became. For decades, the NHIF covered only 19 to 21% of the population, mostly formal, salaried employees. That left the remaining 80%, predominantly informal workers, entirely exposed. In practice, the poor were effectively subsidizing a system built for the wealthy. Beyond the demographics, the institution itself was failing. Systemic inefficiencies, rampant fraudulent payouts, and a massive accumulation of unpaid debts to hospitals crippled its ability to function. To escape this trap, the government drafted the Social Health Insurance Act of 2023. They didn't attempt to patch the existing framework. They legally abolished the NHIF board, specifically isolating and abandoning its toxic debt to start over. Dissolving the NHIF board was a strategic act of institutional insolvency. It allowed the government to isolate billions in legacy debt and clear the site for a system designed to finally encompass the entire population. If the NHIF was a crumbling, outdated structure, the new Social Health Authority is a towering digital skyscraper, one that is currently under construction, even as patients are forced to move into the rooms. This document outlines how the new authority divides medical risk. First is the Primary Healthcare Fund. Fully funded by the Exchequer, it guarantees free preventative care and basic outpatient screening for all registered Kenyans at local lower-level facilities. Step up to a hospital for curative inpatient care or surgery, and you enter the Social Health Insurance Fund. This is the core contributory engine, fueled directly by mandatory premiums collected from households. And if a patient's primary benefits are depleted by a catastrophic event, they fall into the Emergency, Chronic, and Critical Illness Fund. Like the primary fund, this is state-sponsored, acting as a tertiary safety net to prevent immediate household bankruptcy from severe disease. By legally severing preventative care from curative treatments and catastrophic risks, the government is attempting to compartmentalize financial responsibility, balancing a constitutional human right with strict fiscal sustainability. To make the central curative fund work, the authority extracts a mandatory premium of 2.75% from gross household income. Because there is no maximum cap, high earners pay significantly more into the pool than they did under the old system. But 80% of Kenya's workforce operates in the informal economy. Collecting a rigid, lump sum annual premium is mathematically impossible when the majority of your contributors do not have regular, verifiable payroll data. To calculate a fair premium without a pay stub, the authority uses a mechanism called proxy means testing. They analyze a household's housing characteristics and access to basic services to estimate their aggregate income and assign a mandatory contribution tier. To actually collect that money, they introduced Lipa SHA Pole Pole. By integrating the premium collection with existing microfinance structures, like the Hustler Fund, informal workers can pay their required contribution in highly manageable daily or weekly digital installments. But an elegant legislative blueprint is practically useless if the physical collection mechanism cannot continuously process the millions of microtransactions required to keep the engine fueled. It seems like the legislative ambition of this sweeping transition has violently collided with operational reality on the ground. Between October 2024 and early 2026, the rollout has been defined by friction. Patients find themselves trapped in bureaucratic limbo, with hospitals routinely turning away fully paid-up members due to systemic digital failures. The legal framework itself was pushed to the breaking point. The High Court even declared the initial implementation unconstitutional, citing a lack of reasonableness. A complete collapse was only averted by a last-minute stay from the Court of Appeal. Meanwhile, the Ministry of Health is conducting a meticulous audit to reconcile the massive outstanding debts owed to hospitals by the defunct NHIF. Healthcare providers are left waiting, questioning whether this verification process is a genuine push for fiscal accountability or simply a bureaucratic delay tactic. The tripartite fund is a sophisticated piece of legal architecture, but a blueprint cannot provide medical care. Its ultimate success depends on whether the 2.75% fuel actually powers a functioning engine, one that reliably moves the patient from the waiting room to recovery.